الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الصلاة والسلام عليك على رسول الكريم سيدنا ونبينا مولانا محمد وعلى آله وأصحابه أجمعين إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما اللهم صل على سيدنا محمد وعلى آل سيدنا محمد وبارك وسلم. Assalamu alaikum wa rahmatullahi to all of you. I believe we have some 120 participants tonight. And good evening to all our non-Muslim attendees also. A very good evening, a very warm welcome to all of you. And we're very grateful that you attend to our webinars. And I'm sure you're in for a very informative and a very interesting webinar by three excellent speakers, very dedicated pediatricians. And I was going to get one more pediatrician to read the Qiraat before we start, but if it's not available, I will do it. Ibrahim Hussein, doctor, are you available?
Yeah, Assalamu alaikum. I'm here.
Oh, walaikum salam. That makes us have four pediatricians tonight. Alhamdulillah. That's absolutely fantastic. Ibrahim, you could go ahead, please.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. ليس البر أن تولوا وجوهكم قبل المشرق والمغرب ولكن البر من آمن بالله واليوم الآخر والملائكة والكتاب والنبيين وآتى المال على حبه ذوي القربى واليتامى والمساكين وابن السبيل والسائلين وفي الرقاب وأقام الصلاة وآتى الزكاة والموفون بعهدهم إذا عاهدوا والصابرين في البأساء والضراء وحين البأس أولئك الذين صدقوا وأولئك هم المتقون صدق الله العظيم. بسم الله الرحمن الرحيم. The verses I recited are from the second chapter of the Quran, verse 177, and the translation is: righteousness is not in whether you turn your face towards the east or the west. Rather, the righteous are those who believe in God, the last day, the angels, the books, the prophets, who give charity out of their cherished wealth to relatives, orphans, the poor, needy travelers, those who ask, and for freeing captives, who establish prayer, pay the alms due, and keep the pledges they make, and who are patient in times of suffering, adversity, and throughout all periods of panic. Such are the people of truth, the God-fearing. Sadaqallahu al-Azim.
Jazakallah Ibrahim for that wonderful reading and also the translation. I think it makes a lot of sense that you spoke about charity, that you chose verses in the Quran regarding charity, and especially in times of need and in times of stress and what we're going through the COVID period, and in times of difficulty, we should in fact increase our charity. There was a person who used to give charity every month to the tune of about 200,000 rands. And then during the unrest, his shops were looted. And when somebody asked him what has happened, he said, no, I haven't given enough charity. So the concept of charity is absolutely important in times that you can afford it and at times when things are tough. So there's no getting away, and there's Allah subhanahu wa ta'ala, the Almighty, gives you more in return. That's a guarantee. Thank you very much once again, Ibrahim. Just to let the attendees know, Ibrahim is a pediatric cardiologist, So he's one more pediatrician on our panel this evening. Alhamdulillah, Jazakallah khair. We have three excellent speakers this evening, but before I introduce them, just to let you know that this CME program, the webinar, is being recorded. That's one. The second is that it is approved and accredited for 2 points. It will either be one clinical and one ethical, or 2 clinical points. And that should you have any questions, you could post them on the chat, and then we'll take the questions at the end. So that's the procedure for the evening. And I'm Dr. Mohammed Solwa from the IMA in Durban, and together with Shakira and others are involved with the IMA webinars in Durban. As you know, the webinars are national. Some of them are from Cape Town, some of them are from Johannesburg. So the idea of webinars is because of the lockdown, we're unable to assemble in a single venue. So it makes it easy. We're in the comfort of our homes, and we are able to hear wonderful presentations. So tonight we've got all pediatricians, as I mentioned. We've got all pediatricians. The first is Dr. Shakira Kassam. She is the Vice President of the Islamic Medical Association, well-deserved. And also she's absolutely active within the IMA, and also active academically, and a very hardworking physician and a hardworking mother also. So she seems to multitask and do a lot of things at the same time. She has a very extensive CV, but I'm not going to go through that. But just to let you know that she's done Islamic studies also, and is busy with a program that is based in the UK. And I think one of her assignments, or these assignments, was titled Consanguinity. And I suppose the topic is close to her heart, and she's done a lot of research. And I think it's something that we need to be aware of, because there are many complications that can arise from consanguinous marriages and the results thereof. So she is going to lay the foundation for the evening, talk about her experiences and the impact it has as far as public health is concerned. Then we have 3 presentations by Dr. Tahir Mita, who is also a pediatrician in Durban, also a very hardworking pediatrician for some good number of years, but young at heart. And finally, we have the star for the night is Professor Samud Sheikh, who would be talking about the surgical interventions that are required in these children. So this is the format for the evening. So Bismillah, I will ask Shakira to kick off, please. Bismillah.
Can you see my presentation?
It's perfectly fine, Shakira. You can go ahead.
Bismillah ar-Rahman ar-Rahim. Alhamdulillahi Rabbil Alameen. Wassalatu wassalamu ala ashrafil anbiya'i wal mursalin. Rabbi shadri sadli wa yassirri amli wa lil ukhtatan min lisani yafqahu qawli. Assalamu alaikum wa rahmatullahi wa barakatuh. I started with the universal greeting of Islam, which means peace be upon you. I've sent salutations on our Prophet Muhammad, may peace be upon him. And right at the beginning was praises for God Almighty. And I also made a little prayer that I might have expansion of my chest, and that God may remove the knots that are present in your tongue, so that I may be able to deliver the speech eloquently and clearly to you guys. As Dr. Mohammed Solwa has introduced me, thank you very much, Dr. Solwa, for those very kind words. Yes, I am a pediatrician, but I'm also involved in a lot of issues where it comes concerning public health. And currently we've just finished, not only myself, but a few others from Durban and parts of the other parts of the country. We finished 2nd year, and now we are going into the 3rd year of an Islamic medical ethics online course based in the UK. It's called the Al Balag Academy. And one of our modules was Consanguinity, a public health perspectives. and I was one of only 2 students in an international conference to present at given a 10-minute slot. So I just thought, because I had researched the topic, part of our modules, I want to give acknowledgement here to our teacher, Dr. Sheikh Rafakat Rashid, who is not only a medical doctor, but he's also a traditionally trained Islamic scholar. So acknowledgements to him for the encouragement. And second acknowledgement is to Professor Samud Sheikh, who is a pediatric surgeon, but his knowledge is so vast, and he helped me a lot with the presentation as well, and some of the slides actually were his as well. So to go on with this presentation, so the objective of today's talk is to understand the relationship between consanguinity, genetic disorders, and its impact. Now, the outline of this presentation will be such that I will take you through the definition of consanguinity. I'll look at some of the global statistics, give you some examples of clinical problems, also why we worried about consanguinity, the genetic disorders that are caused, and then we'll look at the impact. Now, one would think that consanguinity, it's been around for so many years without any problem, and what's the big deal? And until I did this topic, I also thought, just as much as many of the others, what's the big deal? Because we're not really seeing many problems. However, being a pediatrician and working in the neonatal ICU, and having spoken to some of my other colleagues, we are seeing that yes, there is a small emerging problem here in KwaZulu-Natal and maybe other parts of South Africa. The problem is very small in South Africa, but when I go through the rest of my presentation, you'll see that it can be quite a huge problem. So what's the definition of consanguinity? It's biologically related second cousins or closer, and having one or more common ancestor in common, no more than a grandmother. So every one of us knows what is a cousin, and there's many degrees, right? So you have the first cousin, who is the offspring of your father's sibling. So your auntie's child is your first cousin. Your second cousin is your father's cousin's cousin, and that's how you get second cousins. First cousin, once removed, is so this is here, you are the cousins, so it's your father's cousin's child. So that's one cousin removed. And then you have uncle and niece relationships. Double first cousins is where the parents, the mother was a first cousin, and she married another person who was also a relationship of a first cousin. So the grandparents would be related, the parents would be related. Double first cousins, it's where it's going more in depth in terms of the relationships across the generations. When we look at the map in terms of the percentages of consanguineous marriages, now you will look at this picture, and before I go to the map, just to give you some statistics, about 1.1 billion people live in countries where customary marriages are normal, and 10% of the global population are offsprings of consanguineous parents. So we know that where in the world is the highest intensity or density of consanguineous relationships. So the purple here is more than 50%, and you'll see most of it is in the Kingdom of Saudi Arabia. Then you have Afghanistan, Pakistan. The other areas will be Morocco, Algeria, Libya, Egypt, Sudan, the dark areas. And this is Turkey here, the yellow area. And across Turkey, you get Iran, Iraq, and going on to Afghanistan, Pakistan, and India as well. So you'll see that if we're speaking about 10 billion of the world's population belonging to communities where consanguineous marriages are common, it's still a big deal. Now, if the people of so this is a graph showing you the rates of first cousin marriages in Middle East and North Africa. And it's basically a very similar one to the world map, where you can see as it goes, it's from 20% going on to 25, 30%, going on to 40, 50%. Sudan, Yemen, and you'll see the Middle East countries, South Asia, and North Africa has the highest concentration of consanguineous marriages. But what happens if these population leave their country of origin and move on to other countries as immigrants? Do they still have a high rate of consanguineous relationship? Yes, they do. And if we look at the Pakistani community in Birmingham, in the UK, at least 50% of the Pakistani community in Birmingham are consanguineous relationships. So is the case in Norway, where immigrant populations go, Belgium, and then in Australia, the Lebanese have a high rate of consanguineous relationships. And this actually piqued my interest, where it was a longitudinal study called the Born in Bradford study that was spanning over 20 years or 25 years. It's a longitudinal study when they realized that in UK, the immigrant population were having more problems in terms of intellectual disability, inborn errors of metabolism, and rare problems as compared to the rest of the population in UK and as compared to the rest of the immigrant population. So we have studies from the UK, Born in Bradford, and then in Belgium, they've got studies where they looked at the Pakistani and the Moroccan populations, and they've come up, and I will show you those studies in a bit. Now, what is some of the Islamic perspectives on cousin marriages? So in Islam, there are certain relationships that is no-go and you cannot marry. For example, a man cannot marry his mother or his mother's sister, father's sister, cannot marry his daughter or his stepdaughter or his stepmother, and that you'll get from the Islamic scholars. Also, one important thing, and I think because we're medical audience, we have the concept of breast milk banks. Now, in Islam, if some lady breastfeeds another child, a relationship is established between the two baby, her biological child, and the other child she suckles. So they cannot marry. So you might find in some communities, breast milk bank, especially in the Muslim community, is not, but it's a controversial issue. Now, in terms of, and as Muslims, we follow the Quran and we follow our teachings of the Prophet. And he has not given any report that he advises not to marry cousins. And in fact, in the Quran, there are verses that says that it is permissible for you to marry the children of your father's brother or sister. So you can marry cousins. However, where the consanguineous marriages is frowned upon, and where actually says that try not to marry your close relative, comes from one of the second caliphs, Umar, who actually were the successors of the Prophet Muhammad sallallahu alaihi wasallam, who were the rulers of the Islamic State. And following on the Caliphate, that is the four rulers, came the four schools of thought. Now, among the four schools of thought, Imam Shafi and Imam Hanbali, they also encourage marriages from beyond your kin. So they advise you not to get married to your first cousin. Imam Hanafi, which most of us in South Africa and in the Indo-Pak area follow, and Maliki in the North Africans, they make no mention of marriage to near kin in terms of forbidding it or not. So why would people choose to marry a cousin, a close relative? For a number of reasons. It's more favorable to a woman's status. The wife would have better relationships with the in-laws. It reduces the possibility of ill health and financial uncertainties. And you can have premarital negotiations regarding the financial matters. And this very important thing, it keeps the money and property within the family. It strengthens family ties and enforces family solidarity. So these are some of the reasons why people might choose to go for a cousin marriage, because you know the person, you know the family, and they're very similar in terms of thought process, cultural, etc. So these are some of the factors that increase consanguinity rates. the cultural beliefs. If there's political and civil unrest, as you would see in certain parts of North Africa, there's nobody else you can move out to go to marry. You've in close communities, you will marry the people closest to you. Amongst the first generation immigrants, financial difficulties and female illiteracy was one of the factors that increased consanguineous relationships. However, they found that as females go into the education and in the workforce, they obviously marry later, they have lower fertility, they move from the rural to the urban, better economic status, community education program, hence the rate of consanguineous relationships decrease. Now, is it only a Muslim phenomenon? Definitely not. And I would take you back on a history lesson where there was Charles II of Spain, and because they wanted to improve the territorial influence across Europe, they married a lot of relatives, and they married for wealth, they married for status, and for gaining geographical leverage. So Charles II of Spain was a product of 8 generations of inbreeding. His father and his mother were uncle and niece. Now, in this picture, he's got what they call the Habsburg jaw. It's a very prominent jaw, the Habsburg nose, and this was all very peculiar to these generations of the Austrian-German population belonging to his family. And he was one of the last rulers of Spain. Unfortunately, he suffered a lot of ill health in terms of epilepsy, not being intellectually very bright, and having lots of other health issues, and he died very young. Then these other examples, which we call the founder effect, and it's because of loss of genetic variation where a new population is established from a very small number of people. So for example, you live in a large country. So let's take Pakistan. People live in a large country of Pakistan. They move out, hence they move into other areas. So there's smaller groups of community, and they can only marry within their community. But I'm just using that as an example. But this is what is called endogamy, and it arises from cultural isolation. And things that were rare in the general population become more common and pronounced because these are the founders going on to new territories and discovering new lands. So there are certain examples, 3 examples of endogamous relationships or groups quite well established in medical journals. One is the Amish, 2 is the Ashkenazi Jews, and then the Arabs, which I will focus a lot at the end of the talk on the Arabs. Now, the Amish population, they were a descendants from a limited number of founders, only 70 to 80, who left Switzerland to come to the United States. And amongst them, they discovered, this doesn't project very well, about over 81 genetic disorders. And out of some disorders that may be common, very, very rare in the general population, that may be, for example, cystinosis, maybe 1 in 200,000. In the Amish, it's 1 in 144. And other things that are rare, like maple syrup disease, very common in them, fetal ketonuria, and severe combined immunodeficiencies. Then, as medical students, I'm sure we all heard about Ashkenazi Jews. And this today's population of 10 million Ashkenazi Jews only came from 350 individuals who lived about 600 to 800 years ago. And this community has a lot of disorders peculiar and specific to them, such as family dysautonomia, Tay-Sachs disease, hemophilia C, congenital deafness, and cystic fibrosis. But for me, what was very interesting when I was researching it is this called the Fugates family, which is another example of cultural isolation, founder effect. This origin of the family was a French immigrant, Mr. Fugate, who moved across to Kentucky in the USA, and then he married somebody. And the strange thing, These two were not related, but unfortunately, they carried, both of them were carriers of this rare recessive gene, and subsequently, all the family members or some of them had blue skin. So this was the blue skin. And because of their blue skin, they were in a remote area. People didn't know much of them, but even when they did get to know them, they thought of them as being strange having this blue skin. And they were around for about 200 years until maybe about 50 years ago when one of the children were born, and then they moved out and got investigated, and the condition they had was methemoglobinemia, which gives you a bluish tinge to the skin. Now, what's the genetic basis for the autosomal recessive disorders? So we all know that DNA is the instrumental material, and all our genetic makeup is made up of DNA, and we inherit two copies of the genes, one from your father and one from your mother. So you all get one copy from your mother, one copy from your father, and the genetic sharing in, for example, full siblings, your biological brother or your sister, you carry 50% of the genetic pool. So for example, in families, you might find a similar color eyes or the shape of the nose or the color of the skin. Half siblings, 25% of the genetic makeup. First cousins, 12.5%, and second cousins, 3%. So these numbers indicate the percentage of shared DNA between you and each relative. So, but however, if the relationships are getting more and more intertwined as it's going progressively backwards in the terms of your pedigree, you'll find there may be more and more genetic mixing that happens. This slide talks to, if say you have father and mother, they are carriers, they're not showing any signs, it's an autosomal recessive disorder. So you got a 25% chance of a normal child. You will have a 50% chance of two of them not showing any symptoms but being carriers, but you'll have a 25% chance of one of the child having manifested this autosomal recessive disorders. Now, when we speak about the impact on consanguinity on different parameters, for example, it does affect the female because you'll find that there's decreased fertility, there's increased rates of stillborns, and increased infant mortality rates in terms of female women's health issues. Birth defects, general population about 2 to 3%, but in consanguineous relationships it's 4 to 6%, which by itself doesn't sound too big, but I'll show you other statistics to follow. So this rate of birth defects is doubled in consanguineous relationships. And there's a high risk of offsprings with autosomal recessive disorders. And if a family does have something, and then if they have that disease that's lurking there, and they marry somebody who has the same genetic makeup, there's an even higher chance of it being manifest, and there's a greater risk of recurrence as well. So what are some of the abnormalities that one can come across? So surgical, such as cleft lip or palate, spina bifida, extra fingers, congenital
I just found that one for the
heart disease, intellectual disabilities, blindness, deafness, mutism, developmental delay, intellectual disabilities, muscle disorders, neurological disease, blood disorders, sickle cell thalassemia, multisystem, inborn errors of metabolism, endocrine disorders. So this list is very vast. And when you're taking a history in terms of people who come to you and they may be concerned, you have to delve into the history in terms of, are there other family members who are blind or deaf, have intellectual disability or any congenital abnormalities? Now, with the advance in molecular genetics and the advances in terms of us finding the genome and the DNA sequences, we have been very well placed to discover genetic relationships in terms of faulty genes causing certain disorders. Because of this, we were able to pick up the disorders in the Kingdom of Saudi Arabia. And they have a very advanced genome project going already now about 10 years because they look for these congenital disorders. And as I mentioned, the population initially was the Amish. We spoke about Ashkenazi Jews, and now I'm speaking about the Saudi Arabia congenital disorders. This country has the highest prevalence of disorders per capita in the world. And the prevalence of consanguinity can go up to 56%. And first cousin relationships are most common. You'll find, in terms of autosomal recessive disorder, at least 61% of the abnormalities seen is because of autosomal recessive disorders, because of consanguineous relationship, and the consanguineous relationship is about 50 to 60%. So you'll find that this has huge impact. And while researching this, I didn't even realize that there was such a high prevalence of congenital heart disease in certain cluster areas. And it's not because they're drinking contaminated water or the air they breathe or something. It's because of the close relationships. So look at this area in blue and look at this area in yellow. This has a very high incidence of congenital heart disease. And it's very interesting that we had Dr. Ibrahim Hussein, a pediatric cardiologist who read the verses from the Quran. So he can probably resonate with this much better than many of us who are general peds. Then the red areas are areas where there's high incidence of cardiovascular, musculoskeletal, urinary, GIT, CNS, and cleft palate abnormalities. So you'll find a lot of cleft palate abnormalities. And for those of us, Medina is very dear to our heart, and Makkah. So that's the area where a lot of these abnormalities. And then in the area down south, they have congenital heart, GIT, CNS, small neurological abnormalities. Now, just going one more further, this is the last slide on the Saudi Arabian, but where they found there was consanguineous relationships, this is the 2 pluses, there was a higher risk of congenital malformation or birth defects, higher incidence of cystic fibrosis, hereditary deafness, blindness, visual impairments, thalassemia, sickle cell, and G6PD deficiencies. So this, you can imagine the huge cost associated with diagnosis, management, and some families may not only have 1, but 2 or 3 children who have the problem. The other interesting thing, and this is a very recent study as recent as 2020, where they found that in consanguineous relationship, there's a higher incidence of disorders of sexual development. And they found 77 patients with disorders of sexual development. Our old term would have been ambiguous genitalia in 47 families. Now, in terms of Islamic teachings and management, this does have a huge impact in terms of the rulings in terms of gender reassignment, how in terms of inheritance law for later on, because you have to know which is the correct gender you assign, etc. So, and this ability to fine tune and pick up these rare disorders is only because of the highly advanced DNA analysis and microarray tests that they can do to pick up the abnormalities. Just a few more examples, and I'm almost done in a short while, where we looked at genetics of intellectual disability. Now, this study was one of the highest number of cases, also fairly recent, 2017, coming out of Iran, where previously, if the children had intellectual disability, you wouldn't really know what was the cause of it or what was the problem. But because they were able to do DNA sequencing, they were able to pick up. And why we said this was one of the largest studies, they looked at about 400 consanguineous family relationships. And some of these families had 2 or more children with intellectual disabilities. And they found that they did pick up old problems that they knew existed, but they found new mutations. They also found that it existed in certain clans, that there were certain disorders, and this is the red is showing you the areas where they picked up certain disorders according to certain clans. And so it was clan specific, hence because of the consanguineous relationship. So there was genetic clustering, regional clustering of these disorders. And then they looked at, because they found that in consanguineous relationships, there was 3 or 4 times more risk of intellectual disability. But with this intellectual disabilities, they also found them to have more a predilection for other inborn errors of metabolism. So you find it won't just go with one disorder, they often may have multiple disorders. Now, when they looked at this study, they also looked, so this is coming from Iran, they also looked at the clustering amongst other communities where high consanguineous relationships occur, such Arabs, such as Arabia, Turkey, and Pakistan. And they found that same highly consanguineous populations, severely recessive disorders causing mutations and confined to clans. So you won't find the same genetic makeup for a disorder in Pakistan versus one in Iran. And this actually helps to in terms of prevention and diagnosis. So just to take you back about intellectual disorder and why the Born in Bradford, the UK study was so important and pivotal in highlighting consanguineous relationships, because they found in the UK that in the Pakistani immigrants, there were 3 times more learning disabilities in their children. This is the one speaking about inborn errors of metabolism, and this comes out of a fairly recent study as well, 2018. This was a 15-year study between 2000 and 2010 and in Denmark. And what they found that in consanguineous relationship, they picked up 30 cases of inborn errors of inborn errors of metabolism in these children, and compared to hardly any in the normal Denmark population. And the clusters were higher in the Afghanistan. If you remember my map, I showed you Afghanistan, the Arab immigrants and the Pakistani immigrants. So you can see that there are huge challenges for the families with autosomal recessive disorders in
चलेंगे LENGE.
So that was just to show you the huge challenges, and I'm punning on an Indian word called chalenga, which means let's go. And I'm on to the last 2 slides where the challenges are huge. And I'm sure when Dr. Mehta speaks of his case presentation and when Professor Samud Sheikh describes some of his pediatric surgical experiences, they'll speak more of the devastating, life-changing events for the parents, the huge emotional, psychological, social toll. It affects the marriages. There's ethical issues involved. When do you stop therapy? When do you continue? The high cost of medical care and the huge cost of genetic testing. The recommendations include an informed choice, premarital counseling, testing, not to be judgmental or stigmatize the family, to educate health professionals, create this disease awareness of and public health. So what happened in UK when they found this a problem, and what's happening in other parts of the Muslim countries, we are bringing the medical professional and the Islamic scholars together to try and create awareness. We're not saying that we should stigmatize it. Obviously, there are populations where consanguineous marriages are greatly revered and they get on very well, but we want to create awareness without creating stigma. Thank you so much. This last slide, if any wants, it talks you through pedigree construction, and how you would go about genetic counseling a couple who comes to you with a history and you want to determine their risk. Thank you very much.
Wonderful presentation, Shakira. Jazakallah for that beautiful presentation, and you made it in time, 30 minutes. Alhamdulillah. It shows the Al-Bagh University student. Well done. You laid a foundation for the topic, beautifully done. And I'm sure Tahir will expand, and then in the end, Professor Samud Sheikh will take us through the whole presentation to see exactly where we are, especially in Durban. This would be one of the questions. Do we have genetic testing in Durban? I know there's a huge genome project that is going on in Durban, but that will leave to the end. Once again, I'm sure all of you would agree, Shakira has done a wonderful presentation, and thank you for that. We have now Dr. Tayyib Mita, who is also a physician, a pediatrician, a very hardworking one in the Durban area, based at Parklands Hospital and at the Ahmed Al-Qadi Hospital. And he will be talking to us. He'll be discussing three case histories, and these have been very recent in 2021. So we look forward to hearing from him. Tahir, please, you could go ahead.
Can you see?
Yes, Tahir, we can see.
Okay. Assalamu alaikum. Thank you to the IMA and to Shakira for coordinating this meeting. My job is actually to describe or go through three different patients that we've had. And it's actually recently as within this year. There have been others that we have come across in this year as well. However, we couldn't clearly trace them. They were from consanguinous managers and they did have problems, but we couldn't trace the genetics and therefore they were not included in this presentation. So there's a little bit of overlap between Shakira's and mine, but mine is mainly clinical. So basically, I'm just going to repeat what Shakira said. It's defined as the union between two individuals who are related as close as second cousins or closer. And obviously, because of that, the risk of an adverse outcome in the offspring is an estimate based on family history, degree of consanguinity, and background population risk. So the impact of consanguinity on different health parameters are basically on reproductive health. And you'll see that in some of my patients, there have been miscarriages. Some of them have birth defects, congenital malformations, other genetic diseases, disabilities like hearing and vision, and chronic adult non-communicative diseases later. The available data suggests that stillborn rates are either similar or slightly higher among consanguineous couples than non-related couples. And generally speaking, frequency of congenital malformations among newborns of first cousin unions is about 2 times the frequency amongst the general population. So it's about 4 to 6%. And as Shakira had previously said, that although it looks like it's a small number, when you look at the population dynamics, you will find that this is a significant number of patients. And the offspring of consanguineous parents are overrepresented represented amongst those with mental retardation, blindness, deaf mutism. And these conditions have many etiologies and a proportion of them from autosomal recessive genes associated with consanguinity. So we're going to discuss 3 patients. The first case is a patient AM, born on 3rd of March 2021. The mom and dad are second cousins. She had a Caesar for previous cesarean section. The baby was discharged well on day 2. The family history is that there was a sibling that demised at approximately 8 months of age in 2019 with neonatal diabetes, hepatitis, and the exact cause was not really established. This child presented on day 2 at about 11 p.m. with an apneic episode and a cardiopulmonary arrest. Mom was fairly jacked up, so she brought baby immediately to casualty, and resuscitation had commenced immediately. We had a full resuscitation that was done, which included inotropes and intermittent positive pressure ventilation. But the main features on admission were hypoglycemia, lactic acidosis, and hyperammonemia. So we corrected the electrolyte abnormalities and sent bloods for a metabolic screen. On clinical examination, the patient was a term appropriate for gestational age and was found in cardiopulmonary failure. We commenced dopamine and full ventilation. Once the baby was clinically stable, investigations were sent to the Center for Human Metabolomics at the Northwest University in Potchefstroom. And the result came back 3 days later with a markedly increased 3-hydroxy hexadecanoyl carnitine, a long chain 3-hydroxy acyl-CoA dehydrogenase deficiency. So the diagnosis in her was a mitochondrial trifunctional protein deficiency. It is a severe fatty acid oxidation disorder with cardiac and neurological involvement. And the signs and symptoms of trifunctional protein deficiency may begin during infancy or later in life. And the features that occur during infancy include feeding difficulties, lethargy, hypoglycemia, hypotonia, and hepatitis. And our patient basically had all these features. And the mitochondrial trifunctional protein is a multi-enzyme complex which catalyzes 3 of the 4 chain shortening reactions into beta oxidation of long-chain fatty acids. Clinically, a failure of long-chain fatty acid beta oxidation leads to hypoketotic hypoglycemia associated with coma, hepatopathy, skeletal myopathy, and cardiomyopathy. Complete MTP deficiency often presents with non-specific symptomatology, which makes clinical recognition difficult. Hypotonia and cardiomyopathy are common presenting features, and the differential diagnosis of an infant with these signs should include MTP deficiency. However, in spite of early diagnosis and treatment, only a few patients with this condition have survived. The inheritance is autosomal recessive, and there is an increased risk in consanguinity. Unfortunately, our patient demised at 14 days of age, and after 14 days after admission, rather, and there was really nothing else that we could have done for her. And this is a slide that just showed how the genetic disorder was inherited. In this case, it might have been an unaffected carrier father and an unaffected carrier mother. And you notice that in each pregnancy, there's a 25% chance of having an affected child, and a 25% chance of having an unaffected child, but a 50% chance of having an unaffected carrier child. So that was the first case. The second case was a baby born on the 10th of May this year. Mom and dad are also first cousins, referred for gastroesophageal reflux disease, and then arrived from Maputo with a nasogastric tube in situ, with a differential diagnosis of congenital myopathy or laryngomalacia. So she had the history of 2 miscarriages in the first trimester. And the second one was a baby was born at 32 weeks of age, which was floppy, had respiratory distress, and demised within 24 hours in Maputo before they could seek attention. They did say that there was a shortage of intensive care facilities and ICU beds, and therefore they couldn't ventilate this baby. When I examined this child was clearly malnourished, 2.5 kilograms at birth, and now at 2 months of age was 2.35 kilograms, had a nasogastric tube in situ, had pooling of secretions, but the striking feature was a marked hypotonia with depressed reflexes. The investigations done were routine bloods, including an Inborn error screen, which came back normal. The X-rays that were done was a water-soluble contrast study, which confirmed gastroesophageal reflux disease, and the cardiac and neurological assessment was generally normal. So here was Mr. Sheikh had come in and helped us discussed the issue of offering a peg and a nascent fundoplication, which would have been done laparoscopically. However, they chose not to do this and went back to Maputo with a nasogastric tube in situ. So the features were in keeping with a congenital myopathy or spinal muscular atrophy. Bloods were sent for genetic studies in the USA, and I'll discuss some of the problems that may occur getting genetic studies done. And we're still awaiting genetics associated with SMA type 1, because the primary tests that were done was not, didn't show any real genetic abnormality, but there was a subtest that was meant to be done, which we haven't got the results for that yet. If this test came back positive for SMA type 1, then the child will be a candidate for Zolgensma, which is currently the most expensive drug in the world at an annual cost of $2.25 million per year, which is way above the reach of almost every patient that we know. Here, the inheritance is autosomal recessive also, and it's usually a mutation on the SMN1 and SMN2 gene locus on chromosome 5. And similarly, this is an autosomal recessive, and you've seen this picture before, where there's a 25% chance of each child being affected. But I think we still have to wait for the genetics to come back to tell us exactly, because this mother has had 4 pregnancies and has only 1 surviving child, who's currently myopathic with a nasogastric tube in situ and on oxygen at home. The third case I'm presenting is a baby that was born on the 31st of May. Mom and dad are also first cousins. The patient was referred also from Maputo on day 5, weighing 2.29 kilograms. And the differential diagnosis at the time of admission was an esophageal atresia or a tracheoesophageal fistula. Because of the history of frequent vomiting, and the child had respiratory distress at birth. When we examined the patient here, the child had features of a pneumonia, which we treated and had settled completely. A nasogastric tube passed by Mr. Sheikh went straight into the stomach, so that diagnosis of esophageal atresia or tracheoesophageal fistula was disproved. And the other features that we did find, and we asked the geneticist to have a look, was that the child had multiple features suggestive of DeGeorge's syndrome. And the features were that he had an underdeveloped lower jaw affecting the swallowing, and therefore the baby couldn't swallow, widely spaced eyes, low set ears, a high arched palate. Fortunately, this baby did not have a cleft palate. Now, DeGeorge's syndrome occurs, we have a microdeletion on the long arm of chromosome 22. They have a condition or a description called catch-22, which is cardiac, abnormal facies, thymic aplasia, cleft palate, and hypocalcemia due to hypoparathyroidism. And sometimes they can present just with fits due to the hypoglycemia. And here is an indication of the genetic inheritance. This is an autosomal dominant. It could be either an affected father or an affected mother and an unaffected other parent. And usually the chance of having an affected child are 50%, and the chance of having an unaffected child is also 50%. So I've discussed the 3 patients, and you can see clearly that there is a genetic relationship between them. The consanguinity is probably a major factor in the development or the we're seeing just probably the tip of the iceberg because of the fact that a large proportion of them are probably miscarried, and they miscarry early, and we don't even know about the fact that there may be genetic abnormalities, because as we know, first trimester miscarriages are often genetic in origin. I just recently saw a review article, and this just backs up what Shakira had said previously, but a review article in January 2021, which is still in preprint, from the University of Virginia School of Medicine and Family Medicine, discussing consanguinity and understanding the health risk and guidance for parents. In the discussion, they say that whether they describe consanguinity again as how we previously described, but the estimated percentage of the global population who are offspring of consanguineous parents is a shocking 10.4%, which means that 10%, almost 10% of the population are offspring of consanguineous parents. And the countries they described were mainly North Africa, Middle East, and Western Asia, and mainly first cousins. In some populations, the rate is 50%. And Shakira showed this to us in populations in Yemen and Saudi Arabia. And the reference for this is the Geneva International Consanguinity Workshop report, which was in 2011, done, I think, by the WHO. So marrying with extended families is often associated with survival of lineage, cultural and religious values, reinforced strong family culture, and it's widely practiced in Muslim majority countries, but not directly associated with Islam. It was also, as it was observed in other religious groups within a region, and there's increased risk in the offspring. And the risk of autosomal recessive congenital diseases is increased. And if both parents are carriers, each child has a 25% chance of inheriting the disease. And the conditions include endocrine, metabolic, hematological, which is thalassemia and sickle cell, deafness, and congenital heart diseases, all described previously by Shakira. So the important point here is that the primary care providers are the first point of contact. And the history is important to identify those at risk for genetic abnormalities and existent in family disorders and in the extended family, because the primary care provider would probably care for the whole family and will know about the existence in the extended family. And important questions to ask are history of birth defects, intellectual disability, developmental delays, unexplained infant deaths, blood disorders, and early vision or hearing impairment. And as previously described, counseling should have a non-stigmatizing approach, and the education of family and parents are extremely important. It may well be that with the education, some may choose not to marry their relatives, but even if they do and they choose still to marry, then at least they're aware of the risks and the consequences. Thank you.
Tahir, excellent, beautiful presentations, 3 presentations, and your 3 case histories, in fact, reinforced the whole question of consanguinity and the presentation done by Shakira. So in fact, your presentation and Shakira's complemented each other and reinforced it in our minds. That's important. Okay, I think the last speaker, we haven't had any questions in the chat as yet. So if there are any questions, post them on the chat, please. Our last speaker is Professor Samud Sheikh. He's got an extensive CV, which is absolutely impossible to go through. That's the first thing. At the same time, we're extremely glad to have him amongst our midst. He's a UK ZN graduate. I remember him when he was doing his training, and he was at Parklands as a surgical, I think as a surgeon. At that time, he was helping the IMA to do some circumcisions. You might not remember, but he's gone far beyond. And at the present moment, he is professor of cardiac surgery, pediatric cardiac surgery at Stellenbosch. I suppose he commutes between Durban and Stellenbosch, but it's certainly a real pleasure to have him at this evening's webinar. Professor Samud Sheikh, are you on? Are you ready?
Yes, I am. Assalamu alaikum.
Wa alaikum salam. Jazakallah.
I just want to correct a few things on that, on my CV. I got back from Stellenbosch many years ago, and Dr. Ibrahim won't be very pleased to hear that I'm a cardiac surgeon. I'm just a pediatric surgeon. And I got back from Stellenbosch some time ago, and I've been back in Durban for, I think, almost 5 years now. But thank you for the welcome. And I'd like to thank Dr. Kassam for asking me to contribute towards this particular discussion. I think it's a relevant discussion, but it's a sensitive area. And I'm trying to share the screen. It's a sensitive area, but obviously an area that directly impacts on the practice of those of us who actually provide care to children. And whilst the primary aim of any sort of public health intervention, as Dr. Kassam had discussed, is related to prevention of disease, one must have sort of mechanisms in place to treat those that are already affected by the condition of interest. And in this particular case, it is how we care for the child who is born to a marriage that is consanguinous. There are a variety of different pediatric surgical conditions that most of this short discussion, because Dr. Kassam and Dr. Mitha have made major contributions already and have discussed almost everything that needed to be discussed. My tendency here will be to focus on a brief commentary that will be related to the management of the child who already has an affliction related to the consanguinity. This is a little picture of a child who's still in utero with a meningomyelocele, one of the major structural anomalies that tend to be diagnosed antenatally fairly frequently in children who are born of consanguinous relationships. So everybody's been over this, or the past two speakers, my two colleagues have discussed this in quite some detail. And the important point for me to make is that the majority of abnormalities that you find from these consanguinous relationships are in fact autosomal recessive type of disorders. And the autosomal recessive disorders are a variety of different categories, which I'll briefly discuss just now. But the important aspect of these conditions is that they often lead to developmental delays and intellectual disability combined with muscle disorders, all of which require supportive interventions. And the supportive interventions that we can provide are mainly of a surgical sort of nature. And then once this has been performed, physical therapy becomes more important. The surgical conditions are
You're breaking up, Samud.
more into the multi-factor type of disorders, and sorry, Shakira, you're saying something? Okay, trying to say, but problems, and there are a variety of different surgical abnormalities that can come, that we can identify. For a pediatric surgeon, we can look at congenital anomalies in terms of those that are the structural, or what we call the visible defects. So these are visible defects that are easily diagnosed by doing a clinical examination on the child. And the common structural defects that we find in this group of children include the abdominal wall defects, children who are born with the meningomyelocele, and those with orofacial abnormalities. At the same time, you can get structural abnormalities, which are also functional. And some of these conditions, which we have had experience with over the past few years, are conditions such as the hyperperistalsis syndrome, where children have a gastrointestinal tract which does not work and require nutritional support in order to survive. The second group of defects are the functional or the hidden defects, and these can be broadly categorized into these groups, which have been already discussed by Dr. Mitha and Dr. Kassam. I just mentioned the Gaucher's disease and the alpha major thalassemias here, which I'll briefly discuss later on, because they are an area in which we may be able to offer management as time goes along. This is just a very, very non-scientific data extraction from patients that I had seen. I used the period before COVID. These figures are from 2018, and these are just to try and give you some idea of what is happening locally. There are numerous authors who have looked at small communities in which there are consanguineous relationships, and some have looked at larger populations. The entire spectrum of the anomalies that I have listed have been described in the offspring. And these particular figures have to be looked at in the context of the frequency of congenital anomalies. And overall, congenital anomalies are usually between 1 in every 5,000 to 15,000 sort of live births. So looking at just my practice in the 1 year, these number of patients who had abnormalities from a consanguineous relationship do look, and from my point of view, a significant number of patients that we see per year. The role of the surgeon is several-fold. He has to assist in the diagnosis. This is very important in terms of children who have difficulties in getting enzymatic or chromosomal diagnoses. And as mentioned earlier on, when we look at the majority of the diseases currently that influence or affect children born of consanguineous relations, then many of these can be diagnosed by genetic testing. And despite the fact that we have very advanced genetic aspects, and we have several different labs available to us both locally and nationally, the actual genetic screening for the differences on a microarray type of investigations are fairly limited. We still have to send a number of our specimens off nationally to get results back, but there has been vast improvement in genetic laboratories being established in South Africa, and also a turnaround the results that we can get from and we can effectively now get a genetic result in a patient who has genetic screening done, the result now within 2.5 to 3 weeks, and this is generally be to the advantage of the biopsies. We limited that to a large degree, but often when the results come back ambiguous or more rapidly and significant, and occasionally other structures. And as Jamita about the children that he had consulted me to see during the times that they had been in those patients is mainly supportive because of the large number of neurologically impaired children that are born to consanguineous relationships. They require often support in terms of feeding, and we insert feeding devices such as gastrostomies in the neurologically impaired patient in order to manage the gastroesophageal reflux that is significant in these patients. And in children who have conditions such as Spina Bifida or the disorders of sexual development that Dr. Kassam mentioned in a few of the more severe cases, we may be required to assist with continence surgery. And the goal of all of this is to try and improve the quality of life of both the parents and the child. We can perform splenectomies, which may be curative. And then for the group of multifactorial conditions which present, we will an important role in terms of correction of the visceral and structural effects. Children congenital are beyond the spectrum of this discussion. So I will just basically mention those broadly. Prevention of illness should be our primary aim, and this is very important. importance in this group as well, which of Dr. Kassam. But I also mentioned earlier on diagnosis and fetal interventions that is probably going to help us alter and change the course.
Samud, your presentation's gone off.
Sorry, I'm not sure what happened there. But in talking about the fetal interventions, what we've got to realize is that the congenital abnormality or the actual abnormality that the child has presents very, very early on in life. And often these can be diagnosed fairly early. And as antenatal diagnosis improves, there are a variety of different ways that we can use to try and improve the general condition of these children. Two of the conditions that are particularly important that are already in clinical trial, in a clinical trial phase already, and that will probably have significant impact, especially in terms of the alpha thalassemia major that tends to present in our community, the fetal therapy in the form of the intrauterine stem cell transplantation. We know that in children who have thalassemia major, and this is a condition that presents from an autosomal recessive type of gene, in these particular patients, the traditional treatment is postnatal, intranatal transfusion or antenatal transfusion initially, if they have alpha thalassemia major. The uterine transfusion allows them to progress to a normal delivery. And after delivery, they have multiple transfusions for a long time and often require quality of life. The role of intrauterine transfusion for these children has been well established. It's been around for a very, very long time. And as a form of therapy, it is used fairly frequently. It is performed in a minimally invasive method.
You cut off, Samud.
Sorry, I'm just going to have to. Okay. Is it sharing now?
No. Okay, but if you want to carry on talking, it's fine. Okay, you started screen sharing now.
Okay.
Okay, I can see your screen now. Okay.
So
thanks.
effectively, in the intrauterine transfusion, that's the standard of care for patients with thalassemia major to ensure that. And what we do for these children is you can do with ultrasound guidance or shown and blood vessels are present. So you can cannulate the vessel and transfuse them. What has been done recently and what we are trying to do is actually do maternal stem cell harvesting from a bone marrow of the mom and then transfuse these intrauterine into the fetus. And this maternal fetal stem cell transplantation is thought to improve or will probably improve the outcome. It's very early in terms of clinical trials. Patients are slow to join these kind of trials. But the important thing about it is that in the few children that this has been tried, we have had some success. Similarly, for children with sickle cell anemia and in some children with neuromuscular disorders, there is the scope or there is the possibility of intrauterine gene therapy, mainly because the fetus lives in a relatively immunocompromised state, allowing for earlier intervention. So in one of the conditions that Dr. Mita spoke about, and he spoke about the most expensive drug in the world that can be used, there is a possibility that if this drug is administered in the intrauterine environment, if a diagnosis is made antenatally, then it is possible that the result in the gene alteration may be maintained for the child's lifetime. Currently, if these medications are used, they have to be used on a regular basis in order to maintain, to stem the disease from progressing. So in terms of fetal intervention, there has been some progress. This is something that we can offer and something that holds place, that will hold its stead in the future. In a small group of children, we can also offer them antenatally management of the actual problem, like a spina bifida. These can be antenatally repaired. So you can see on the top picture, the mom's uterus and the spina bifida being repaired on the back of the child, which is visible in the open wound of the uterus. And in the picture below, it's a very useful intervention that we now have when these children are born, is that before they are disconnected from the placenta, so cesarean section is done and the child's head is delivered. And as soon as the child's head is delivered, the patient is intubated and maintained on the placenta. So mom gets no tocolytics and any sort of agents to help expulsion of the placenta. And whilst the baby is then connected to the placenta, we operate on the child in an operation that we call OOPS, or an operation on placental support. This allows us, for example, in this child to do a thoracoscopy and to remove a segment of non-functioning lung tissue that was acting as a shunt and stealing most of the cardiac supply, with the child having a degree of hydrops and cardiac failure. So overall, the aim behind these interventions is to try and in some way offer children, where we diagnose these conditions, an antenatal form of intervention so that their postnatal quality of life is better. Whilst we can look at preventing this from happening with the view that non-consanguineous relationships may limit these diseases from occurring, this is a double-edged sword. There are two possibilities. In the one possibility, we can localize the disease and eradicate the condition. So if consanguineous marriages continue, then you maintain the pool of defective alleles within a very small community. And in this community, there is a high chance then of the disease presenting in its major form, and effectively you'll get self-selection of the disease and ultimately eradication of the disease and the carriers over a relatively short period of time. The alternative view, where we don't look at consanguineous relationships as being acceptable, allows for wider spread of these abnormal alleles. So these things spread out in the world, go all over the world, and although the gene pool becomes diluted, there are a larger number of recessive genes floating around in the general population. And over a period of time, because this is an exponential function, there is a greater likelihood of disease occurring. And future generations, the estimate is probably 3 generations from now, the number of people at risk of developing major forms of this disease will be significantly higher than we have at present. So overall, what I've just tried to do is give you an overview in terms of the surgical interventions. Dr. Kassam and Dr. Mitha have covered most of this and most of the areas where we are involved in. But I think it's important to understand that we need to try and prevent these diseases, but at the same time have to accept that when the children are born, we have to have some sort of measures in place to be able to effectively treat them and at least improve the quality of life for the parents and the child. Thank you.
Thank you very much, Professor Samud. Quite a detailed and rather complicated information to a lot of the doctors. A lot of them not aware of these opportunities available to help these kids. But certainly there are questions in the chat room, so we'll go through the questions, and I think maybe one of you can answer them. Whoever is sort of willing to answer them. Let me just start opening them up first. Okay, just to start off the questions, there are certain communities, for example, in India, the Parsi community. It's a very small community and they marry amongst themselves. And then Dr. Mohammed Timol asked about the Jewish community, Jews. Has there been studies done in these groups of people, and has anomalies been increased in these populations?
When we have any difficult questions, I always say I'll ask the prof. And the prof is with us today, and we want to really acknowledge Professor Samud for all the work that he does for us as pediatricians. As far as I know, the Jewish community, they've managed to come down a lot with much of their inborn errors and other inherited disorders by very rigorous screening procedures and premarital testing. The premarital testing also in certain parts of Saudi Arabia, where they screen for like thalassemia, sickle cell anemias, and G6PD deficiencies. As much as more in-depth detail with the Jewish community, I haven't really looked at that in detail, I must admit.
Okay, I think that's a fair answer given. Prof. Samud, you want to add anything to this from your experience and reading?
Sorry, my experience in terms of antenatal
From your
diagnosis.
reading in these communities and the sort of defects or anomalies that are present here?
I think in terms of the defects, they fall into all the categories that I mentioned earlier on. The very specific defects like Tay-Sachs disease, for example, some of the enzymatic deficiencies, routine screening, like Dr. Kassam has mentioned, has limited the number of patients who present with this, or basically help select in terms of care of these children. So yeah, I think the disease specific to certain communities doesn't really affect it doesn't affect people as much now as it used to because of the spectrum of disease. Sorry, I hope that answers the question.
Okay. There's a question from Dr. Rashid Adam Mohammed saying that, Salams, many parents struggle to get comprehensive workup for these conditions from the general pediatrician. Do we have institutions in South Africa that specifically specialize in diagnosing and managing these conditions?
Samud, do you want to take that?
I think purely from pediatric surgical point of view, each one of the big cities has a center. There are still very few of us, although our numbers are increasing dramatically. But in terms of all 8 major cities in the country does have a pediatric surgery facility available, and they usually work within a center which provides support for all of these children. From a pediatric point of view, there are doctors who have specific interest in some of these conditions, but I think we lack a single central institution where all of these patients could be referred to. Given the distribution of patients, the type of patients we see, the type of population that we have in South Africa, the fact that it's so diverse, I think it's probably better that there are pediatricians within each community who are general pediatricians, but do have some skill in this condition rather than having all the patients referred to a single center simply because the treatment is not over a couple of days. The treatment is ongoing for many, many years. So no, we don't have a proper center, but in terms of general workup, I think most of the major cities do have doctors who will be able to manage these conditions.
All right, especially in Durban, do we? I believe we have a genome project going on at the University of Natal, KwaZulu-Natal. Do you interact, Prof. Samud, with them, and are they helpful in diagnosis of these abnormalities?
Sorry,
yes,
Samud.
Shakira?
Just to add that we do have a genetist in Durban, and genetic services are often overworked as well. And we also have the blood test going, as Tar said, some go to Pretoria, some go to Cape Town, some go to overseas. The other thing is there's a society called the Rare Disease Society where children with very rare disease, and it's some kind of support group that may help certain parents, but I do agree it's something that we really need to create an awareness for and try and do as much as we can.
Okay, just a follow-up to that question in the sense that do pregnant or do couples get advice and counseling services? Are there counseling services available for couples or prospective couples so that they can plan having a child and know the chances of them having an abnormal child or abnormalities? Because that will go a long way to make people aware that these conditions do exist and there are chances, maybe whatever the chance, that your child could have these abnormalities. Are there prenatal or pre-conceptual or premarital counseling services in Durban or anywhere in South Africa?
Okay.
Can I talk about one?
Go ahead.
Basically, yeah, we've only got one pediatric geneticist in the whole of KZN. And I think she's probably overworked. However, with my one patient that we have got a diagnosis with, and the parents are keen, these parents are now, because obviously they've lost 2 children, they've got one live child who's probably very unwell as well. The parents are keen to have genetic tests done so to predict whether they'll have a normal child or they will have an affected child in the future and what's the risk of it. Unfortunately, the cost is extremely high, and bloods have to go to a company called Invita in the US, which costs approximately $2,000 US.
Yes. Okay. Then coming to something that is more common and widely present, for example, diabetes. We know it's so common, especially in the Indian population. At the same time, we have, if you take the Muslim population, particularly, we tend to marry within our own community and our own kind. Those rules are breaking away now, but certainly there are a good number of families who would look for brides or grooms within the inner circle. And that inner circle may not have a very good gene pool. So is there any advice there for the community?
I think maybe all 3 of us should give our parting comments. For me, the purpose of this whole session was to create awareness in terms of first creating the awareness that such a problem exists. And with Prof. Sheikh showing his statistics, I even didn't realize it's so vast. And then we should, if the community still wants to marry within, but at least they know they're going into it with their eyes open now, with the whole background of knowledge that's available. And I see one of the chats, that's Lisa from Sanofi, who does rare diseases, and her comment here was the tests go for lysosomal storage disorders that go to the various to go to NW, I think it's at Northwest University, for a few of the inborn errors of metabolism. She has listed them on the chat for anyone who wants to see it. That will be my last few parting shots. And I'm hoping that we can get people to start being broad-minded and think out of the box now. And because these are young parents, some of them, who've suffered quite a few pregnancy losses and loss to children.
Okay, Abdul Samad, there's a question for you. I think I need to ask you this. This is from Abdul Khalik Desai. Dr. Abdul, he addresses this to you. I have a 32-week pregnant patient with a fetus with intestinal obstruction. How would you manage? He mentions anal-intestinal obstruction. So I suppose it's in that region. Would you advise him, please? A 32-week pregnant patient. The diagnosis, I'm not sure. I think if you can start off with the diagnosis, how is the diagnosis made? And then what you can offer as a surgeon to a 32-week pregnant mother.
I did reply privately to Dr. Desai, but intestinal obstruction type of abnormalities are very difficult diagnosis to make in terms of establishing the level at which the obstruction is. And the obstruction could be anywhere from the stomach all the way down to the anus. But these moms will usually have polyhydramnios. That's the usual initial indicator. And then they will have dilated loops of bowel that are fairly easily visible on ultrasound. For the intestinal obstruction group of conditions, which can be caused from atresias to anorectal malformations, those patients are best managed with a delivery at term in a center where there is a pediatric surgeon available, and then postnatal management works very effectively for children with gastrointestinal obstruction. So I think that for that particular patient, they should deliver at a center where there's a pediatric surgeon available. If you deliver outside of a center where there's a pediatric surgeon is available, and the child has to be transferred to the unit, then your morbidity and your mortality increases dramatically. So the one big advantage of antenatal diagnosis in this situation is that the child can be referred early on.
Okay. Shakira, you can read this. It's from Lisa saying, Ray Diagnostic Services offer a 6-plex test. That makes sense to our pediatricians. This is sent to Northwest University. So I suppose you'll know about this.
Yeah, this is university. Yeah, sorry, this is the test that we used for sending our to confirm the test, the conditions that we have. But there's also a another test which is available at birth, and it's called the extended Hill-Prick test for inborn errors of metabolism. And this test also goes to the Northwest University, and we get results fairly quickly, often sometimes before the presentation of the illness. So, I mean, it's something that you can advise. Unfortunately, it costs 1,800 rands for the test to be done. But I think that it's actually quite a useful test, although the yield is a bit low. But I think for that particular family, or if we have a previously affected child, then I think that the risk is the test is actually very worthwhile.
Okay, Lisa Namara says regarding these tests, they are at no cost to measure the enzyme levels. So this is from the University, Northwest University. I think this is, we've come to the end of question time, and I think we've had a good number of questions, good number of participants. It just leaves me to thank all participants and all the 3 speakers for an excellent presentation on their part and extensive preparation that they've done. I think all attendees have expressed their sort of appreciation to the talks this evening. We've had almost 200 and about 158 stores with us at the moment. I just want to mention a few things. The first is there are many of us in the community who are ill, many of our colleagues and many of our family members and the community as a whole that are ill, and some of them are having COVID. So we ask for Shifa, we ask for complete cure from these illnesses. Professor Ismail Hafaji is a pediatrician. Many of you all would know him. He used to be a consultant at RK Khan Hospital, and then subsequently in private practice, he had a subspecialty in pediatric surgery, not pediatric surgery, pediatrics as a pediatric physician. So he's very ill, I believe, and I would request for dua for him. And also, it's about a year now since the late Dr. Munshi, who was an anesthetist and was implicated in the death of a youngster in Johannesburg. So he was shot down about a year ago in a very gruesome manner. May Allah subhanahu wa ta'ala raise his status and obviously calm his family with lots of patience. So those are the 3 messages And now I think we'll close off. I must thank you once again to all of you. And then, as I mentioned, the recording is present, and you would get a recording or you'll get a transcript of the talks. So we'll close off with the dua now. And the dua for the non-Muslim listeners is that basically we're praising Allah, our Creator, and we're sending salams and salutations on His most treasured Prophet and Nabi Muhammad sallallahu alaihi wasallam, peace be upon him. And we ask Allah, our Creator, for help and guidance, and we ask Him for cure from every form of sickness. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام عليك على رسول الكريم سيدنا ونبينا ومولانا محمد صلى الله عليه وسلم ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار ربنا ظلمنا أنفسنا وإن لم تغفر لنا وترحمنا لنكونن من الخاسرين ربنا لا تزغ قلوبنا بعد إذ هديتنا وهب لنا من لدنك رحمة إنك أنت الوهاب ربي اجعلني مقيم الصلاة وذريتي ربنا وتقبل دعاء ربنا اغفر لي ولوالدي وللمؤمنين يوم يقوم الحساب ربي اغفر وأنت خير الراحمين ربي ارحمهما كما ربياني صغيرا رضيت الله رب الإسلام دينا محمد مصطفى صلى الله عليه وسلم نبي رسولا ربنا هب لنا من أزواجنا ذرياتنا قرة أعين واجعلنا للمتقين إماما ربنا أتم لنا نورنا فاغفر لنا إنك على كل شيء قدير ربنا آتنا من لدنك الرحمة إنك أنت الوهاب ربنا لا تؤاخذنا إن نسينا واخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين اللهم ارزقني نورا فوق نورا تحت نورا يميني نورا شمال نورا اللهم ارزقني العافية اللهم ارزقني العافية في الدنيا والقبر والآخرة والفوز بالجنة والنجاة من النار إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما اللهم صل على سيدنا محمد وعلى آل سيدنا محمد وبارك وسلم دعواهم فيها سبحانك اللهم وتحيتهم فيها السلام وآخر دعوانا أن الحمد لله رب العالمين. Jazakallah to all of you from the Islamic Medical Association in Durban and as a national organization, and we continue to support our webinars in future, inshallah. Jazakallah once again to the speakers. Assalamu alaikum wa rahmatullahi wa barakatuh to all of you.
And once more, Mohammed Salwa, thank you to Femida for our digital service provider. And we've had a husband and wife team with the Femida Sheikh and Professor Samud Sheikh. Jazakallah.
Jazakallah, thank you for stepping in because I always tend to forget something or the other. I suppose we're all human. Okay, Jazakallah once again to all of you who have contributed and especially to the couple. Assalamu alaikum wa rahmatullah.